All right, welcome everyone. My name is Rhiannon Adams. I am a proud supporter of the Louisville Hospital Women's Society. I'm also the co-chair of the Supporter Experience Committee. For those of you who don't know, the Louisville Hospital Women's Society is a group of women in all ages and stages of life who are passionate and committed to raising excellence in women's healthcare and treatment. The Women's Society raises awareness and important funds for a variety of initiatives at the Louisville Hospital for Women. We host our Mind and Body Talks as an inclusive speakers series to engage and stay connected with our community. Tonight's presentation is in partnership with the Alberta Women's Health Foundation and the Women and Children's Health Research Institute. And I'd like to introduce Jenny to speak more about these great organizations.
Thank you so much for the introduction. My name is Jenny Nasuhovsky, and I'm the Senior Strategist, Corporate Partnerships with the Alberta Women's Health Foundation. I'd like to take a moment to thank our sponsor and ally in women's health, Alberta Blue Cross, for making this What the Health event series possible. You may have noticed, as Rhiannon mentioned, that this event also features, in addition to the Louisville Hospital Women's Society, two other organizations, the Alberta Women's Health Foundation and the Women and Children's Health Research Institute. The Alberta Women's Health Foundation is a division of the Royal Alexandra Hospital Foundation dedicated to raising money and awareness for women's health research. Our efforts directly support the work being done at the Women and Children's Health Research Institute, Canada's only research institute dedicated to women and children's health and its intersection in perinatal health. The Alberta Women's Health Foundation, Women and Children's Health Research Institute, and the Louisville Hospital for Women work hand in hand through clinical care, research, and advocacy to improve health outcomes for women across Alberta. Tonight's topic of endometriosis and pelvic pain is a great example of this collaboration and cooperation and that approach to tackling a pervasive issue in women's healthcare. Before I pass it back, I would just like to say another thank you to Alberta Blue Cross, and thank you to our speakers today, Dr. Kruger and Lux, for sharing your experience and your expertise with us so we can get a better understanding of this very important landscape in women's health. Thank you.
Thank you, Jenny. Now a bit of housekeeping. So before we dive into tonight's session, I'm going to provide you with a quick overview of the evening and just a couple of housekeeping notes. Tonight, we're honored to have two guest speakers, OBGYN Dr. Kruger and Lex, a patient advocate directly impacted by endometriosis. We're hoping you will come away from this presentation feeling educated about endometriosis and how you can support yourselves and your loved ones. So this is a safe space for everyone to come and have their questions answered. If you have a question for the speakers, please type it into the chat box. And we'll read it during the Q&A session following the speaker's presentation. You can also put it in the Q&A box. We'll keep our eye on both of them. I see there's already potentially two questions, so I think that'll be a fun part of the evening. This lecture is going to be recorded and is currently being recorded, and it'll be posted on the Women's Society YouTube channel following the presentation. We are using Zoom webinars, so each panelist will appear as they speak, and you will not need to worry about your own video being displayed. So we hope you enjoy this viewing experience. We're also using the live transcript function. So if you'd like to see the available transcript, please enable it on your personal computer. There will be a survey emailed following this lecture, and we'd love for to get your feedback. It helps us figure out what topics we're going to do and just to hear more about what you thought about the presentation. So everyone who fills one out will be entered to win a draw, or will be entered into a draw to win a $25 gift card courtesy of Alberta Blue Cross. So a big thank you to Alberta Blue Cross for your continued support, which allows us to run this informative speaker series. So I'd like to welcome Ashley from Alberta Blue Cross to say a few words.
Thank you so much. Thanks everyone for taking time out of your schedules tonight to join us. I'm so happy to be here representing Alberta Blue Cross, and I really can't wait for this presentation tonight. Before we get started, I just want to take a few moments to do a land acknowledgement. All right, so today and every day, we respectfully acknowledge that we are on the traditional lands referred to as Treaty 6 territory. We recognize that the City of Edmonton and us, the people here, are beneficiaries of this peace and friendship treaty. Treaty 6 encompasses the traditional territories of numerous Western Canada First Nations, such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We are taking this important moment here today to acknowledge all the many First Nations, Métis, and Inuit people whose footsteps have marked these lands for centuries. Thank you so much.
Thank you, Ashley. So I'm excited to present to you our first speaker, Dr. Kruger, and he's a practicing OB/GYN at the Women's Health Clinic of Edmonton, where he focuses on minimally invasive genealogical surgery in the field of general and urogynecology. He is an expert in the management of complex urinary bladder and pelvic floor disorders, as well as endoscopic management and benign genealogical conditions. Please welcome Dr. Kruger.
Can you guys see just the presentation screen?
Yes, it looks great.
Okay, Rhiannon, thank you for the kind introduction. So my interest in endometriosis was actually sparked when I was a medical student. My dad is a REI physician, so he works with people that have infertility. And as a medical student, he was at my university, so I really enjoyed assisting him in laparoscopic surgery, and that sparked my interest. Eventually, I went into that and urogynecology. So I'm happy to share my experience in my practice with the patients that experience endometriosis. So I'll start off with the statement: pelvic pain and painful periods is not a normal rite of passage. I think in the past, the statement was not a fact, but I think us in the medical profession hopefully has made some strides in how quickly we diagnose an endometriosis, and also how effectively we treat our patients. The bottom line and the take-home message for tonight is: if your pelvic or period pains and pelvic pain interfere with your daily activity and quality of life, it deserves investigation and further management. So to understand endometriosis, it's important to understand the normal menstrual cycle. And so I'm going to just go over some of the basics. I know this slide probably looks very technical, but I'm going to point your attention to a few things. So we have the brain, specifically the hypothalamus and the pituitary gland, and then the ovary. So they call this the hypothalamus pituitary ovarian axis, and it's actually your brain that controls your menstrual cycle and your ovarian function. So the important thing to understand is that your endometrial tissue is directly responsive to the production of estrogen, the main female hormone that's produced by the ovary. And that gets signaled by the brain, first by the hypothalamus and then by the pituitary gland. So in the beginning of your menstrual cycle, after you had your period, the lining is extremely thin. The brain then stimulates the ovary to produce estrogen. The estrogen then builds up your endometrial lining throughout the cycle to the point where you ovulate. And over here, you'll see that, so this ovulation occurs in the ovary. And it's actually amazing how this works. So you release an egg every cycle, and then that cyst that ruptured in the ovary forms what we call a corpus luteum cyst. And that then produces the second important female hormone called progesterone that breaks down the lining. So it causes the endometrium to shrink and basically to collapse, and that's when you have your period. And that's an important point to remember when we talk about the treatment of endometriosis. But that brings us to the definition of endometriosis. So what does it mean? It means the endometriosis is basically the endometrial tissue that is anywhere outside of the uterus. and that is not normal. So we can find it in the pelvis most commonly in people that have endometriosis. So it can be on the ovaries, on the fallopian tubes. You can just follow my cursor here. On the ligaments that support the cervix, so that's called the uterosacral ligaments. And then on basically any surface area of the pelvis and the abdomen. So we often found it, well, we can find it on bowel, and that can cause bowel symptoms. We can find it on the bladder, that can cause bladder symptoms. It can even be found in the lungs and very rarely in the brain. And that also demonstrates the different reasons why we have endometriosis, and I'll share that in the following slides. The important thing to remember is endometriosis is extremely common. So 1 out of every 10 female patients will have it in their lifetime. Unfortunately, it takes a long time before we make the definitive diagnosis. Basically, when you have endometriosis, it causes inflammation, and that can lead to either pelvic pain or infertility or subfertility, or combination of both of those two problems. It is unfortunately also a chronic condition, and it's dependent, like I said, on estrogen. Female patients, all females produce estrogen until the natural age of menopause. So menopause is also a treatment of endometriosis. We know that endometriosis basically dies out after a woman enters menopause. The treatment is tailored according to a patient's specific symptoms, so whether it be pain or infertility. And the treatment will definitely vary according to what your main symptoms are. The causes are also multifactorial. The one, when I was a medical student, that made the most sense to me was retrograde menstruation. So if we go back 2 slides and I show you this picture of the uterus, retrograde means moving in the opposite direction. So typically when you have your period, the endometrial lining will get shed through the cervix, through the vagina, and outside. But in a small percentage of patients, you will have flow through the fallopian tubes into the pelvis. So there is an open communication to the pelvis through the fallopian tubes. The important factor to remember is that retrograde menstruation is probably more common than we think, and definitely more common than endometriosis. That means there's other factors playing a role in the disease process. So genetics definitely plays a role, and in the way that you might have a failure of the immune system to destroy these endometrial tissues that end up in the pelvis. So if somebody does not have a genetic mutation, if you have retrograde menstruation, you have cells in your body that will just kill the tissue and it will be gone. But if you have the genetic predisposition, those cells can grow. We also know that the cell lining of your abdominal cavity, called the peritoneal layer, those cells can sometimes undergo changes, and we don't understand why, but into tissue that act like endometrial tissue. So they will be responsive to estrogen and progesterone. We also know that endometriosis can spread through your blood system and your lymphatic system, and that's why it can sometimes end up in your lungs. There's no communication between your abdomen and your lungs, so the only way it can get there is either through blood or through your lymphatic system. And that happens rarely, but it does happen. So I would just highlight the fact that genetics and failure of the immune system probably are more or less the same thing. So here I'm going to show you a picture of normal pelvic anatomy. This is a laparoscopic picture of how a normal pelvis would look like. So you can see on the right-hand side, there's a scope that goes through the belly button, and then it looks at the pelvis. And there you can see the uterus from the top. The uterus then has the fallopian tubes on the sides. This is called the round ligament. At the front of the uterus, you have the bladder, so where my cursor is. And just to orientate you, if you look at this picture of the laparoscope, in front of the uterus, you have the bladder. In the back, you have the rectum. So there is the rectum with your laparoscopic view. The ovaries are just underneath the fallopian tubes. You can barely see them on this picture, but you'll definitely see them in some of the following pictures I'm going to show you. So I'm going to just show you some pictures of endometriosis and how it can look like. So the top two pictures or views are actually a normal pelvis. So again, you can see the uterus, the fallopian tubes, the ovaries, and then in the front you have the bladder, and then this part of the bottom is the rectum. It looks more or less the same on this picture. Now, if you look at the picture below, then you see these black nodules. You also see scarring of tissue. So, different organs that get stuck together. So over here, you have the black nodule, the ovary is stuck to the back of the uterus and to the supporting ligaments. And you have a similar picture on the right-hand side. And then this ovary here is swollen and has a cyst in it. It's called the endometrioma. This is another picture. So that we call these blueberry spots. So you see these blueberry spots all over. So this would be a grade 2 endometriosis. You do grade them according to the severity of the laparoscopic findings, and that can be from a 1 to a 4. And interesting, I'll mention again a bit later, the laparoscopic findings has a direct impact on maybe your fertility, but not how a patient will experience pain. So just a few other findings. So here again, black spots, all signs of endometriosis. And here the ovaries look swollen. They will have the typical endometrial cysts. If you pop this, if you remove the cyst and you rupture the cyst, they have this typical chocolate-like fluid appearance. And that's basically the endometrial tissue bleeding into the ovary month after month after month. And sometimes they can cause huge cysts. The inflammation also causes scarring. So you can see the scarring between the different organs. And again, this picture at the bottom shows the blueberry spots. And then if you look at the top here, that's scarring of the bladder. And I'm going to show you a short video of bladder endometriosis, which is actually quite rare, but it's interesting to see. So at the end of the day, endometriosis means it's endometrial tissue that survives outside of the uterus. It's dependent on estrogen, the main female hormone. And through inflammation, it causes pain and infertility. Very common. It affects about 5 to 10% of our population. It's 3 to 10 times higher if you have a first-degree relative like a mother or a sister. And if a gynecologist is investigating somebody for pelvic pain, and you do a laparoscopy, you would find it in almost 1 out of every 2 women. So extremely common, especially if you have pelvic pain that affects your quality of life. So gynecological pain comes in many different forms. That can be painful periods, painful intercourse, painful urination, bowel movements, and just a feeling of chronic pelvic pain and discomfort. And then, like I mentioned, you can have infertility, but it can also be subfertility. So a definition of fertility would be if you can achieve a pregnancy within 6 months of trying. Subfertility is when you would take longer. So it's not impossible for people with endometriosis to fall pregnant or to get pregnant, but it definitely affects how quickly you would get pregnant. So the public also needs to understand when your period pains aren't normal. So like I said, if it affects your quality of life, if you take over-the-counter pain medications and it doesn't really help, if it's associated with intense backache, if you cannot do your normal physical activities, then more rarely, if you have diarrhea or constipation or blood in the stool, that means endometriosis is actually going into the rectal space and tissue. If you have bladder pain or pain with urination, pain during intercourse, those are, and then also pain that's not associated with your period. I would just highlight here that the diarrhea, constipation, and blood in the stool, as well as bladder pain, those are rare examples of endometriosis. The others are more common. But endometriosis, unlike cancer, typically responds or would not invade a whole plane of tissue. So it's rare for endometriosis to go through the bladder or through the rectum. It does happen, but it's extremely rare. Where cancer will just ignore tissue planes, endometriosis typically will adhere to tissue planes. It will just make things get stuck together. And like I said, it's sad, but it typically takes 7 years to correct the correct diagnosis of endometriosis. I'm hoping that this fact is changing, and I think maybe I think Lux will give us some more comments on this. But through talks like this and awareness of increased public awareness, we can change this. So knowledge is power, and the more people know about the symptoms, the easier you will be able to get to an accurate diagnosis. So the main question is, does it interfere with your quality of daily activity or quality of life? And if it does, this is not normal. You have the right for a referral to a gynecologist and also to ask for a pelvic ultrasound. I'm going to talk about the imaging in a bit, but if you do get referred to a specialist, you should expect that the physician will have ask about a detailed pain history, and he or she might include a pelvic exam. Some of the basic investigations will be a pelvic ultrasound, and then depending on the ultrasound findings and the findings of the history and the physical exam, you might ask for he or she might ask for an MRI, diagnostic laparoscopy, and then a blood test called the CA125. So this is not specific for endometriosis. So CA125 we typically would ask for if you have a complex ovarian cyst, and this is something that can happen when you have endometriosis, but it's also a tumor marker. So it's just one of the diagnostic tools, but it's not something that we're going to ask for in every patient that has endometriosis. Doing a diagnostic laparoscopy is no longer required for diagnosis, so you can actually start treatment prior to doing a diagnostic laparoscopy if you have a high suspicion of endometriosis. And the reason is that any surgery has complications. So your risk of a complication just with a basic laparoscopy is 9%, but it's still the gold standard for diagnosis and classification of severity. And the reason is even the most sophisticated imaging, namely the MRI, cannot pick up those fine nodules of endometriosis that are the blueberry spots that I showed you previously. So only a laparoscopic surgery can diagnose and see those lesions. So the treatment, like I mentioned, this is a chronic condition. There's no magical cure. There's no silver bullet. And unfortunately, it's a progressive disease. It can be treated, but treatment is individualized according to infertility or pain, and also medical versus surgical, and we'll go into that in a little bit. Another important thing is somebody with a grade 1 endometriosis can have severe pain, and somebody with a grade 4 endometriosis can have minimal pain. So the way that endometriosis is classified is according to laparoscopic findings, but not according to a patient's pain symptoms. So that's important to realize. But typically, if you present to your GP's office with pelvic pain and a suspicion of endometriosis, they will start you on anti-inflammatories. We want to avoid codeine and morphine type medications because, like I said, endometriosis is a chronic condition that will need treatment for a long time. And if you are on any type of morphine or opioid medications that will be habit forming. You can use those types of medications in episodes of acute pain, but definitely not for long-term management. Combined hormonal contraceptives is the first-line therapy. So it's specifically effective for painful periods, but not that effective for management of pelvic pain. And actually, its effectiveness is limited. So if you think of the combined hormonal contraceptive or just a birth control pill, it has quite high doses of estrogen and progestin. Estrogen, like I said, stimulates the endometrial tissue. The progesterone will reduce the estrogen effect, but it's, estrogen still has an effect. So although it's a first-line therapy, it's not a very effective therapy. And typically when I would never, as a specialist provider, recommend it, because by the time patients present to me, that they've tried that. In a limited portion of the population, it will work. But with more severe disease, we're looking into other treatments. So specifically treatment or hormones or a medication that only has the progestin or that suppresses estrogen production. So a very effective treatment for endometriosis is Vizan. It's a type of progestin. It works well for pelvic pain and dysmenorrhea. It's well tolerated. You can use it long term. There's no side effects in terms of bone mineral density. And it can be used as a contraception, but it's not being actually, interestingly enough, in Europe, it's classified as contraception, but not in Canada, although it does work. But those are just, technical things. So another type of progesterone is called the Depo-Provera or Depo-Progestin therapy. The brand name is Depo-Provera. Very effective. You have some loss in bone mineral density. It's quite economical. The nice thing is you inject it intramuscular every 3 months, and you don't have to think about taking medications. So the effect is thinning of all endometrial tissue in the uterus, as well as any ectopic endometrium. The downside is that you have systemic absorption of this progesterone. And so typical people have a little bit of fluid retention and weight gain. And there is quite a bit of evidence for mild depression. So definitely not my first line therapy, but it's cheap and effective. So, I'm from South Africa, where not everybody has access to, good medical insurance. So that would be a good type of treatment for patients that don't have access to good insurance in countries where there's a two-tier system, medical system. The Mirena IUD is also a very effective treatment for a specific type of endometriosis, and that's adenomyosis. So on the picture on the right, you can see these nests of endometrium that have moved into the muscle or the myometrium. So on ultrasound, typically the uterus will have a globular appearance. I'll show you some pictures of that later on. But so the reason the Mirena works good in this condition is because it's so close to the area of therapy. The Mirena releases a type of progestin, and it gets absorbed in the uterus, unfortunately, and fortunately doesn't get absorbed in the whole body. So the reason why that is good is because you don't have any systemic side effects of hormones going through the whole system. It only circulates locally through the uterus. The downside is that it's not good for pelvic endometriosis. So then there's a medication called danazol, and personally I've never used it in my life. It is apparently good for endometriosis related pain. The reason it's not really used in Canada is because it has androgenic or male or testosterone type side effects. So that can include acne, muscle cramps, swelling of tissue, weight gain, even deepening of the voice, and growth of hair in a male type of distribution pattern. So then we get to the mainstay of medical therapy. So this is typically what I would use. So one of the medications is called Lupron. It's a GnRH agonist. And I don't want to bore you with physiology, but basically it works at the level of the hypothalamus. So it causes, so it's a little bit counterintuitive, but it stimulates the release of GnRH, growth hormone, releasing hormone. And it stimulates it to such an effect that the hypothalamus gets depleted, and then it doesn't secrete any GnRH anymore. And then that leads to decrease in follicle stimulating hormone and luteinizing hormone. And that decrease then produces no estrogen, that causes no production of estrogen and progesterone. So basically you go into what we call a chemical menopause. So no estrogen and progesterone production, which means all the endometrial tissue shrink. And like I previously said, if you go into natural menopause at the age of 51, that is actually the best treatment for endometriosis. So it does come with side effects. It comes with the side effects of menopause. And that means that the main symptoms will be hot flushes and night sweats, and also loss in bone mineral density. Estrogen is responsible for the density of your bones in your premenopausal years. So to counter this, we will give what we call add-back therapy, which means we give you low doses of estrogen, and not enough to stimulate endometriosis production, but enough to prevent hot flushes and not for your bones to thin out. So recently, so that was a mainstay, and it still is. The same company then produced a medication called Orilissa, and this is an oral medication. So I would just go back to this slide. The Lupron is an injection you take every 3 months. Orilissa is an oral medication that you take daily, and it has the same effect. It just decreases the release of the growth gonadotropin releasing hormone. That in effect causes decreased FSH and LH and decreased estrogen and progesterone. So basically it has the same effect as a Lupron. But the only difference is with Lupron, if you don't give add-back, people will go into menopause. With the Orilissa, it works, but it doesn't block the hypothalamus completely. So you still produce small doses of estrogen and progesterone, enough that you don't have the symptomatic symptoms of menopause, but that it does impact or it does not stimulate endometriosis. So then we move on to surgical therapy. So with surgical therapy, we offer to patients that don't respond to medication, or for some reason they cannot take the medication. Also with patients that have deep invasive or severe disease, we know that medical therapy will not resolve their symptoms completely. The other instance would be if you have a big ovarian cyst, a torsion or rupture. Those cysts, once they form, they don't resolve completely. And the reason for that is there's no blood supply. So once you have an endometriosis cyst, no amount of medication or lack of estrogen will shrink it. It will stay like that. It will just not get bigger. So when we talk about surgery for endometriosis, we talk about surgical therapy that is either conservative or more invasive. So with conservative or definitive. So with conservative therapy, our aim is basically to restore normal anatomy, and we can do that for 2 reasons: to increase your fertility chances or decrease your pain. And the gold standard is for the surgeon to cut out the nests of endometrium. In the past, people used to burn it a lot, but there's really good evidence that suggests that burning endometriosis, so just coagulating it, does not work. You have to actually excise the lesion. So that's the important thing to ask your surgeon prior to going for surgery. Are you going to excise the lesions or just burn it? Excising is the gold standard. So I'm going to show you quite an interesting video. So this is a video one of my colleagues took in South Africa of somebody that has bladder endometriosis. And like I mentioned, this is actually quite rare, but it's interesting to see. So I'm not going to play the whole video, but I'll just play the, the images I think are quite interesting, or the parts I think are quite interesting. So here we enter through the urethra into the bladder, and I'm just going to pause. So now we're looking at the area just as we enter the bladder. All these red lesions and the black dots, so this whole area here is abnormal. The good thing is it's above where the ureters run into the bladder, so it's a safe place to dissect out. But you would not be able to burn it. You actually have to physically remove this to cure the patient's symptoms. So we're going to go over that. So this is the view from the cystoscope, and now we're going in laparoscopically through the belly button and some side ports. This is the uterus. It's interesting, you see here how the omentum, the fatty tissue, is trying to protect the lesion, or to protect the body from the lesion. So it actually covers it. It's called the omental fat pad. Now I'm going to fast forward to where we actually enter the bladder. Okay, so here you can see a big hole in the bladder. This lesion has been excised as close as we can. On the other side, you can see the balloon that's in the bladder. So that's at, this is the endometriosis that's been excised. And now the bladder will be closed and the lesion is gone. The downside of doing the surgery is that you lower the capacity, the volume that the bladder can store, but there's no other good way of surgically treating it. So we're just going to close that. So I'm going to move on to the next slide. I just thought it was quite interesting. So when we talk about definitive surgical therapy, basically, when you have definitive surgery, you have to remove the ovaries. Removing the ovaries stops the production of estrogen and stimulation of endometriosis. It's not something that we would typically do unless we have severe endometriosis if you're in your premenopausal years, because estrogen is really important up to the age of natural menopause. So if you ever have to remove the ovaries, then you have to give estrogen add-back therapy, so that you don't have bone mineral density loss and you don't have hot flushes and night sweats. We also typically would remove the uterus and the tubes because that will remove the painful periods. Any nodules or lesions that I showed you previously would also be removed. And this is only done if you have failed medical management or severe disease. And obviously you're finished with with family planning. And this is very much a personal choice. So especially in your premenopausal years. I would just add that laparoscopy is preferred to open surgery. And the reason is, like you could see in the image I just showed you, you get great visualization. This is not the same with open surgery. So you can even see the smallest lesions. The benefits are also you get quicker recovery, typically less blood loss. You can do more accurate surgery. And then I would also say, apart from definitive surgical therapy, if you have cysts that are bigger than 3 centimeters that are thought to be endometriomas, it's a good idea to excise them. If they're less than 3 centimeters, you can sometimes observe them. So now we're moving on to fertility and endometriosis. So I'll just mention a few quick facts. Somebody that has infertility and endometriosis, or specifically endometriomas, which means cysts in the ovaries due to endometriosis, they would benefit from removing these cysts prior to IVF therapy. If you're not undergoing IVF therapy and you have infertility, surgery is not the be-all and end-all. So you would have to do 8 laparoscopic surgeries for 1 additional natural pregnancy. So then that's specifically for stage 1 and 2 endometriosis. We also have to remember, if we do surgery, you should tell your patient that you can expect the endometriosis to return. I typically use this example. So if somebody presents to me at the age of 30, it took them from the first period when they started producing estrogen until the age of 30 to present to me, so they can expect the same course going forward. It's not going to return the next year, but it will slowly return. Some additional therapies that I will just mention might be mindfulness therapy, and this can be done if you have a counselor or psychiatrist trained in this area. You can also see dietitians for the diets that can reduce inflammation, and that might be diets that are low in saturated and trans fats, reduce red meat consumption, a gluten-free diet, a decreased alcohol and caffeine consumption. Some physiotherapists focus on pelvic pain and pelvic health, so that's also a good option. And then there is also some evidence for acupuncture for the relievement of pelvic pain associated with endometriosis. And then lastly, I just want to conclude with good patient resources. So the Society of Obstetrician and Gynecologists of Canada, which is our national body, has a good website called yourperiod.ca that talks about what is normal, what is not normal. Then the WHO, if you Google WHO endometriosis, you'll also get some good facts about this condition. ACOG is the American College. They have good information, as well as AAGL, which is the American College for Advanced Gynecological Surgery. So that concludes my talk, and I'll hand over the rights of the talk again.
Thanks, Dr. Kruger. You can stop sharing your screen.
Okay, so I'm just going to say stop share. I'm just going to close this this window behind me, the shades behind me.
Okay, it's all good. So thank you very much, Dr. Kruger, for that really informative presentation. It was great. I learned a lot, and those were pretty interesting pictures. So thank you very much. Next to join us and share their story is Lux. Lux is a patient advocate directly impacted by endometriosis. So thank you, Lux, for joining us.
Hi, thanks so much for having me. So I guess this is my story about my journey with endometriosis. It started when I was about 13, I believe, is the first time that I ended up in the hospital. And quickly, like through that year of repeated visits to the hospital, it became very obvious to me what was going on. And that was because my mom had endometriosis. So had she not had endometriosis, there would have been, I think, a much longer time to figuring out what was going on, because no doctors, even with my mom standing there saying that she had endometriosis, that she had the same symptoms, the doctors still didn't know what it was. And that was about 15 years ago. So at that time, it was like almost impossible to find a specialist. Nobody had any idea what we were talking about. And doctors repeatedly told me it was normal. And so even with that advocacy from my mom, we were still not able to find treatment. And so I spent the next 10 years after that in excruciating pain, being pulled out of bathtubs and because I couldn't stand up after trying to soothe my abdomen with hot water, pulling over on the side of the road because I couldn't continue to drive, monthly hospital visits, prescription to morphine. I had a morphine prescription by the time I was 20. Around 20 is when it sort of started to escalate, and I was put on, like Dr. Kruger explained, many of the hormonal birth controls. They tried those from the time I was 14 to 20, and then eventually somebody proposed Bizan to me. And Bizan was sort of like the first endo treatment that I was given. And I was a bit hesitant. My mom had done Lupron and she found the side effects really hard of like the shift in hormones. And so I was a bit nervous about Bizan. I went on it. I had pretty severe psychological side effects with Bazan, which doesn't happen to everybody, but there is a large group of people that it does happen to. And so I did it for 6 months. It drastically decreased my pain, and I ended up having 2 years of almost pain-free periods after that. So for me, it was a short-term solution that helped me. There was a little bit of a trade-off in terms of my mental health, but when you're in chronic pain every day, those things are a delicate balance anyways. And so I took Bazan. I had a couple of years of pain-free, and then it came back with a vengeance. And it just continued to escalate through my mid-20s into the point where I finally found a doctor who I demanded to give me a laparoscopic surgery. And at this point, I had been asking for 15 years. And so the thing that led me to patient advocacy was essentially that I didn't have a lot of say in the care that I received, no matter what I told the doctors or what new information I provided them or new research that was available. The only thing that they kept repeating the same offers, which was birth control, and I don't deal well with hormones. And so I had been asking for laparoscopic surgery to diagnose. We knew that I had large endometriomas. I had 2 endometriomas at that time in my mid-20s that were, I remember being the size of a baseball each. And so quite large. We found those because I was peeing my pants. I have bladder endometriosis. And so that was a journey as well. But eventually I found a doctor that performed laparoscopy on me, and that was only last year. So I'm coming up on the first year since my first surgery. And it went okay. I ended up having the worst year of pain of my life, which is a little bit of an unusual circumstance after surgery, but we're not sure what happened. I ended up developing more endometriomas, ending up in the ER, had a cyst rupture, so a couple more things. And then eventually, which is so funny, it's interesting to hear different doctors talk about which methods they've used or seen used, because now I'm using danazol, which nobody uses. But as a non-binary person, the side effects weren't something that I was concerned about. And so I've been using danazol for about 6 months, and I'm pain-free. And I don't know how to put it any other way, but I feel really great. I have another laparoscopic surgery scheduled. But my journey with all of that chronic pain essentially led me to trying to understand deeper what chronic pain meant. And so because there are not a lot of treatments for endometriosis, I stepped outside of that and was like, what is the damage done to my nervous system from being in pain all of these years? And how can I manage that? If I can't manage my endo, because there aren't a lot of options left for me, what can I do? And so that led me to founding Some Days, which is a period pain relief company. But the point of Some Days was to shorten the diagnosis to endometriosis for people and to offer them some sort of respite in the meantime. So what I mean by that is that we know now that chronic pain obviously it starts in your brain. And so you build these pathways that essentially continue to send pain signals, even if that pain is not as extreme as the interpretation. And so we're interpreting all sensations as painful. And when we use mindfulness, like Dr. Kruger said, or somatic therapy, or essentially bring joy to areas of our life that have been filled with pain, we're able to find relief in a different way. And using those sort of therapies and embodiment practices have brought me a lot of peace that even the most drastic of interventions weren't able to do. And so I feel really optimistic about the new treatments that are coming out. There's so much new research. There's so many new treatments. And also there's so much more information about chronic pain. And I really encourage anybody who is struggling with endometriosis or chronic pelvic pain to explore those modalities. They sound soft compared to like getting surgery or taking a medication, but they're equally as important, especially while we wait for a cure. And so, and that's really the combination of those things is what has brought me to the place that I am. And I'm really grateful for all those tools. There, that's my story.
Thank you, Lex. I'm going to turn it over to Crystal to do the Q&A.
Hello, everyone. So my name is Crystal Jacob. I am a proud supporter of our Lois Bowl Women's Society, and I am co-chair for our Supporter Experience Committee, and I will be moderating tonight's Q&A. So thank you very much, Lux. It's so important to have people share their stories. I know that a lot of individuals suffer with this, and it is quite comforting to hear that other people are also going through similar issues. And I'm sure there are many individuals who can relate to your story, and you're doing amazing things there in Vancouver. So thank you for that as well. We have lots of questions, so I will get started. So first question is, what is the time limit that's considered to be safe to be using Lupron Depot? I've been using it for almost 6 months thus far.
So if you take it with add-back therapy, it's actually can be a long-term therapy. Typically, we would reevaluate after 2 years, but that's so if you don't take the estrogen and progesterone with it, then it is limited to a shorter time frame, and I would not recommend going longer than 2 years.
Okay, thank you so much for that. Next question we have. I used to have very painful periods, even when taking iron a week before my period. But I have found doing yoga regularly since that, I haven't noticed when my period has started. Should I still seek a doctor?
I would say no, if you're asymptomatic. So, this is something, so endometriosis is very much, we treat your symptoms. So it's not unreasonable to get an ultrasound just to get peace of mind, so that you know that you don't have, like I said, you can have more severe disease without any symptoms. And it's possible that, what you're doing at the moment, the yoga, is working to the extent that it's, suppressing your symptoms. So if you want complete clarity, I would just do an ultrasound if that's normal, and your GP can arrange that. And if that's normal, I would not worry too much about it. And maybe, Lux, I don't know if you can comment on how effective, I mean, if you separate the danazol with then the therapy, like you said, you were doing mindfulness therapy, how much of an improvement on top of the medication it gave to you?
Yeah, we have a lot of people in our community who have used pelvic floor physio, pelvic yoga, and find intense relief. There's lots of evidence, which I'm sure you are aware of, that the pelvic floor becomes so disrupted. And so it makes perfect sense to me that yoga would work for some people when chronic pain just transfers to other parts of your body. And when you're protecting that area for so long and experiencing so much trauma there, that the release of yoga would make sense to me.
Yeah, and I would also just add to that, that, like, it's a little bit off topic, but if people with endometriosis can develop these chronic pelvic pain syndromes, and it's because of upregulation of your pain sensation. So how your body perceives pain is heightened. And you often see people that have endometriosis, but also have maybe inflammatory bowel disease, chronic back pain, like I said, chronic pelvic pain, to a point where your pelvic muscles can go into spasm, and then it cannot relax. So that's where pelvic floor physio really plays a big role. And there's other things you can do, but chronic pain is basically a disease process because of the upregulation of your pain sensation.
Very interesting. I think that's great that some people are getting relief with these other modalities. That's fantastic. So our next question is, can the infertility caused by endometriosis be reversed?
It's So, like I said, endometriosis is a chronic condition, but it's also important to understand why infertility happens. So it also depends on where the endometriosis is. So if you have endometriosis affecting the fallopian tubes, for example, sometimes you can get a swollen tube. It's also called a hydrosalpinx. And that tube can then release toxins that go back into the uterus, and it can decrease implantation. So if there's damage to your tubes, unfortunately, it's often permanent. But if you have mild endometriosis, and it's treated effectively, sometimes it's not going to affect you long term, but it's really individualized. We know that endometriosis is quite common in people seeking IVF therapy or infertility therapy. And one of the things that we do then is we check for swollen tubes. If there are swollen tubes, we know endometriosis can go into the cavity and affect the implantation rate of IVF. So it sounds counterintuitive, but people that have decided IVF therapy is the only way that they can get pregnant because they've tried maybe for 5 to 10 years. If they have swollen tubes, we recommend to take them out because it increases your IVF rates. So that's an example of where, yes, it can have chronic impact.
Okay, very good. The next question, do they check your cervix for endometriosis during a
laparoscopy?
Possibly.
Possibly laparoscopy. So the cervix is in the vagina, but a portion of it is, you can see laparoscopic. So it's rare to have endometriosis on the cervix in the vagina, but it's very common to have it in the abdominal portion, so where the uterus sacrals connect to the cervix. So we do check for that laparoscopically, but we don't check the vagina apart from doing an internal exam. But typically, if you do, and even if you do a pap smear, for example, you don't check for endometriosis specifically, and it's very rare to have endometriosis on the vaginal portion of the cervix.
Okay. Our next question is from Sunny. I'm on Ulegolix. 200 milligrams. What long-term impact does this medication have? I've been awaiting a hysterectomy since November of 2020.
Yeah. So I spoke about Orilissa, that's Ulegolix. It's a fancy name for it. The dose that this patient is taking or person is taking is a higher dose. So that causes complete suppression of estrogen. So that is then similar to Lupron without add-back therapy. So again, the recommendation definitely would not be to be longer on that for 2 years, because you will have menopausal side effects and you will have decreased bone mineral density. That means you're at increased risk of fractures later on in life. So definitely the 2-year mark. And I would say that, when was her surgery scheduled? Did she say, or she doesn't know? She's waiting, right?
Just waiting.
Yeah. So hopefully it's within 2 years. And I would recommend something suppressive after that. So once she has surgery, that I would recommend the lower dose of Orilissa, which is 150 after she has surgery. That means she's still producing a little bit of estrogen, enough to prevent menopausal symptoms, but not enough to stimulate the endometriosis.
Okay, thank you for that. Very informative. This next question, and I think Lux, maybe you can add to this as well. At what point should one go to the ER with period pain?
Lux, you want to start? You have first-hand experience.
That one makes me laugh because I want to say never, because they can't do anything for you in the ER, unfortunately. And so it's a bit of a complicated question, because if the question is actually when should I seek care, anytime that your pain is disrupting your life. Like, one of the biggest messages that we try, that at some days that we are trying to get across is that period pain is not normal, that your suffering is not like a rite of passage, exactly what you said in your first slide, Dr. Kruger, and that if it's pain that's disrupting your life and significant enough that you're considering seeing a doctor, see a doctor. Unfortunately, the ER is absolutely not going to do anything other than inject you with an opioid, which maybe will help you temporarily. But it's very important to limit your expectations of what they're going to do for you, because it is absolutely nothing that's not their purpose. So it sounds terrible, but it's a reality, and you could waste a lot of time going there looking for answers because they won't give you any.
I would 100% agree. That's just not the way that our medical system works. So the correct way to deal with it is to get a referral to a specialist that focuses on endometriosis. Or they will at maximum do an ultrasound and hopefully get a referral to a gynecologist. But that's the pathway that you need to start to follow, is to get specialist help.
Very good. Thank you both. Our next question. I was diagnosed symptomatic about 6 years ago. I was put on an oral contraceptive as treatment. About a year ago, I stopped taking these and have very manageable periods and period pain now. Is there any reason to return to drug treatment? A more general version of this question, does it have to be treated? Which I think you did touch on, but if you just want to add a little more, great.
Yeah, no, again, it's not a bad idea to get a pelvic ultrasound as a baseline, because you don't want to you don't want to miss things that are there that need to be monitored. You can have patients, like I mentioned, that have severe disease with no symptoms. So the way that the oral medication works is it does suppress it to some extent, but it's not a long-term treatment. So as soon as you stop taking it, that same disease process will start again. And again, like I mentioned, the typical person will maybe wait, a few years with the endometriosis developing before they seek medical care. So you can expect the same thing to happen again. So whatever you waited your time of seeking help the first time, you can expect something similar the second time around.
Okay, fantastic. What are the differences between endometriosis and uterine fibroids? Are there any medical treatments / surgeries that can be performed to either reduce the size of fibroids or remove them completely?
Yeah, that's a good question. So I mentioned adenomyosis, and adenomyosis is endometriosis in the uterus. And that can sometimes be misdiagnosed for fibroids. So to get back to the diagnosis of fibroids is actually where the muscle layer gets a mutation and it starts growing as a soft tissue tumor. It's not cancer, it's a benign growth, but the muscle layer starts to grow and gets bigger. Adenomyosis is where the endometrium goes into the muscle and starts to grow. So it's two different things. Both can have an effect on fertility. Fibroids by itself is not painful. There is medication that is effective for the treatment of fibroids if you have symptoms. So Lupron, again, because fibroids is also an estrogen-dependent tumor. So Lupron, or there's a medication that was taken off the market called Fibristol. Unfortunately, that was also for fibroids, but those are the only two medications. Arulissa is not meant for fibroids. And then if your fibroids impact your fertility, or it causes pressure symptoms like obstructive urination, or pain or pressure on any organs in the pelvis, you can actually have them surgically removed, and that can be done laparoscopically as well. So that is something that we do very commonly. But you have to have symptoms related to your fibroids. Fibroids by itself is also extremely common. So if you would examine every single woman that had a hysterectomy at the age of 50% of them will have some evidence of fibroids in it. And it's only a small percentage that cause problems.
Okay, very good. I believe you touched on this as well. Does chronic pain lead to being more sensitive non-endo pain? Lux. saying absolutely.
Yeah, Lux, do you want to comment?
Yes, that's a huge one. I mean, I was just speaking with another doctor who specializes in endometriosis, and they're talking about central nervous system sensitization, and just when you suffer from pain continuously and it becomes chronic, it can heighten everything else that's happening to you, and then you end up with other like coexisting issues like pelvic floor dysfunction or things like that, because your system is just on such high alert. So absolutely can make you more sensitive to essentially everything, emotionally too.
Yeah. Yeah, and again, I totally agree with that. We see that all the time.
Okay. There's a few questions that are a little bit similar. So it looks like individuals are having a hard time kind of navigating the healthcare system or being seen by an appropriate specialist. A lot of questions regarding advocating for themselves and how do they go about kind of navigating through the system to get the answers they need.
You know, like I started off in Canada as a GP prior to specializing, and I remember the frustration as a general practitioner not having all the answers, and women will often come with non-specific pelvic pain, and the thing is, the GPs have often very limited. You know, some people are specialized in this area, so I'm generalizing, but not all some GPs will maybe have 2 to 4 weeks of gynae training in their whole medical career. So you can't expect them to know all the answers. So that's why it's so important to have talks like this, just to raise public awareness. So you should advocate for yourself. If you think your periods and your pelvic pain is impacting your quality of life, you're missing work, missing school, missing activities, those are reasons to be referred, and you can ask for a referral. You can also ask for a pelvic ultrasound. So those would be the 2 basic things that I would, definitely ask for.
Sorry, I'd like to add to that, if that's okay. Or are we running out of time? Is that what you're popping into? Just to add to that, there's lots of patient advocacy groups, and they're great resources for like doctors in specific areas. One that I highly recommend is the Happy Pelvis on Instagram. I believe that her website is also the Happy Pelvis, and her and another patient advocate have put together this incredible like 30-page document of resources in Canada specifically, and it's about all sorts of pelvic conditions, and invaluable resource.
Yeah, so I was just going to follow up really quickly, and it's just along that line. Is there any sort of resource that says these doctors or these people are very specialized in this, and this is a list of people who would be really helpful to, who would be able to help you or know what they're talking about when you come talk to them? Are there any lists like that? Maybe like that's on the resources you were talking about.
Yeah, that's in the resource guide.
Okay.
And also Nancy's Nook on Facebook is like a giant Facebook group of people with endometriosis about every single there's information about every doctor, every person, everything related to endo on there as well.
That's great.
That is something I don't know.
That's awesome. Okay, this is an interesting question. Just a question regarding retrograde menstruation. I joined a bit late, sorry, but does the doctor feel like that is an explanation? I know that Dr. Redwine's research may have disproven this. Can you comment?
Yeah, like I said, it's to me, when I was a student, it was a theory that made the most sense. But it's endometriosis is for sure multifactorial. So we often find a little bit of blood in the pelvis when we do laparoscopy for other reasons. And those patients don't have endometriosis, but the tissue ended up there. So the body has to deal with that tissue in a certain way. Some people, and I think most people will have some element of retrograde menstruation, but because of genetic predispositions or abnormalities, your body doesn't have the ability to kill those endometrial cells in people that have endometriosis. So that is the difference. That is how it gets there, but how your body deals with it is the difference between getting endometriosis or not. And that's a genetic and gene factor, and research is still ongoing in that area. So hopefully in the future, we will have specific genetic panels that can test for these predispositions. And people are working on it. And, maybe like I said, I'm not that associate, that I'm not in like a researcher in the field of endometriosis. I'm mainly a surgeon. But I know that those panels are probably 10, 15 years away. I don't know if Lux has any other, like contacts with physicians that has given her any other information.
Yeah, I was just speaking with an endometriosis researcher on our Instagram, which you can see. There's a video, it's about half an hour long, Dr. Paul Young, and he's talking specifically about those, about new research that's come out and updated things. So I would recommend watching that. And also endometriosis surgeon on Instagram. He also does live video of endo surgeries, and he is like one of the top endo surgeons in the US and has lots of information about what's changing and new information. And sorry, you were speaking about something genetic panels. Yeah. He said, the researcher said about 5 to 10 years away.
5 to 10 years. Yeah, that's the info I have as well.
Very good. Yeah, it's interesting that you both talk about this and you say how common it is and how many individuals suffer with it. And then when we look at the research, it's so very little thus far. Okay, so we will continue on. There are a lot of questions. I really hope we get to touch on most aspects of this topic, but we may not get to everyone's questions this evening, but I will try my best. I've been diagnosed with severe endometriosis. I am currently on a cancellation list to go for surgery. My fertility doctor has prescribed me Lupron, 1 shot per a month dose. I am experiencing all the hot flashes and menopause symptoms. Is there anything I can do to get rid of my symptoms?
Yes, definitely. You should have add-back therapy. So you can ask your doctor about that. So I specifically, so the thinking about it, it's a little bit counterintuitive, but add-back means you're giving enough estrogen back that you don't have side effects, but it doesn't stimulate endometriosis. So if you think about menopause as well, the amount of estrogen that we give somebody when they're in the menopause is much lower than their body would have produced premenopausal, but it's still enough to fight the hot flashes and night sweats, and that's what you want. So that is a very easy treatment, and you can definitely ask your doctor about that. And I would suggest that you do.
That's great information. Okay, so many questions. I have had a laparoscopy, but the endometriosis has grown back, and also with adenomyosis. I already struggle with my weight. What would the best treatment for me be?
So with adenomyosis, I really prefer the Mirena IUD, and the reason is because you don't have the systemic side effects of weight gain. And like I said, the reason the IUD works specifically with adenomyosis is the proximity of the hormone to the treatment. So the Mirena isn't great for endometriosis in the pelvis, but it's not working at all, but it's really great for the endometriosis in the muscle of the uterus called adenomyosis, and that's what she says she has. So that would be my top choice. But again, you can discuss that with your healthcare provider.
Very good, thank you. Can you explain more about the different types of endometriosis? My daughter has stage 1 clear endometriosis, as well as the red markings, and has extreme pain.
So again, that is something we hear all the time. So she describes grade 1. The red lesions are superficial lesions, and that because it's a chronic disease, that's how it starts. It starts with the red superficial lesions, and it can develop into more severe disease later on. And like I mentioned, grade 1 disease can be debilitating. and because it only focuses on that diagnosis focuses on your laparoscopic findings, the pictures that I showed you. So it is a progressive disease, but it sounds like it's quite early on. So I would start with the just the first line therapies like contraceptive hormonal therapy, like the normal birth control pill. If that doesn't help, like Lux mentioned, she was on Vizan, that it helped for pain. But I also want to mention I cannot tell you this is the best treatment for you. Often it takes a few trials of different therapies where you find this is the one that works for you. And I see that all the time in my practice. So I wish I could say this is the best. Lux said that danazol worked for her. And she tried Vizan, it worked for pain, but gave her the mood swings, or the psychological aspects weren't great. So treatment is individualized, and there are different treatments available. So if one doesn't work, the next might.
I just wanted to add quickly to that which I can't remember off the top of my head, but the Dr. Paul Young in that video on our Instagram is Get Some Days, SOMEDAYS. He speaks specifically about the stages, and that they're eventually planning to move away from that system into a new system based on new information about different types of endometriosis. And so if she knows what type and where that endo is, that video might speak a little bit more to like what the effects of that specific type of endo are.
You're right. So they're trying to move away from that initial classification system because it's not great for evaluating pain. So some people at AHL is our laparoscopic body. They have recommended that there should be two different classification systems, one for fertility and one for pain. And so that is new research that might come out in the next few years. So it's definitely a developing field, and it's worth keeping an eye on the research space.
Absolutely. You guys have given so many resources, so thank you very much for that. And Lux, you know all the ins and outs on social media, so I think that'll be interesting to go through as well. Okay, so we'll do a few more questions and then we'll wrap up, just to be respectful of everyone's time this evening. So the next question comes from Katrina. I have a 5-centimeter endometrioma on one of my ovaries, which was seen with ultrasound. Specialists I have been seeing said he would not want to surgically remove it because of how large it is, for the risk of decreasing my fertility further. Should I seek a second opinion?
Yeah, I would seek a second opinion. The current guidelines suggest that cysts that are bigger than 3 centimeters should be excised, because especially if you're symptomatic. He is right that the risk of surgery is that you decrease your ovarian reserve, but it's very much tied into the skill set of that laparoscopic surgeon. So in the past, like if you want to specialize in endometriosis surgery, you have to do a fellowship where you are trained to try and preserve as much ovarian tissue as possible. So with somebody that doesn't do a lot, yes, you can decrease your ovarian reserve. It's definitely a possibility, but the current recommendation is that anything larger than 3 centimeters be removed, because there's a very small chance it will resolve by itself.
And thank you for just touching on the latest guidelines, keeping us up to date. Lastly, in the Q&A, I know there are some questions in the chat too, however. Is it important to wait until family planning is finished before getting a laparoscopy?
No, because there's 2 different types of surgery. So one is conservative, and the one is more invasive, or so the short answer is, if she has failed medical management, you do not have to wait until you finish childbearing, because Conservative therapy focuses on only removing the active endometriosis lesions, but preserving your fertility. Definitive surgery means removing the ovaries, but you do not need to do that. If you've failed medical management and you still want to have kids, you actually increase your fertility rates if you remove the active endometriosis lesions, at the time of surgery.
Okay, so I'm going to do one last question because I see it in the chat and it's pretty long. So I feel like they put in the effort to ask, so we will try and answer. Okay, so this is from Tara. I have stage 4 endo and have suffered for many years before being diagnosed with a laparoscopic surgery like many others. When I was diagnosed, I had never heard of endo. Thankfully, in the years after being diagnosed, it's been more widely talked about, like tonight. So thank you all, and thank you to the speakers. I have suffered subfertility for a long time. After 8 years and a second surgery to remove endo from my bladder, bowels, and ovaries, I did get pregnant for the first time with only fertility drugs, but sadly miscarried a year later. I did get pregnant and currently have my rainbow baby. Being pregnant was the most pain-free I have ever felt since getting my period. And because I did breastfeed, my period thankfully stayed away for quite some time, but it is returning now and seems to be gradually getting back to where I was with my pain. Is it just inevitable that it will be back to where it was with my cysts and the pain?
So it's interesting what you mentioned. So two things physiologically. A third of pregnancies, or a third of patients with endometriosis will get better when they're pregnant. And we don't understand why it is, because your estrogen hormones, although the type of estrogen differs, actually increases. But we know that a third of patients will get better. Then she breastfed, which means she is suppressing estrogen production. So that would make sense. When she stops, then if she's not on any birth control pill, her hormone levels will normalize, estrogen levels will normalize. So eventually, the thinking is that the endometriosis will return. But it's also, I would say if she responded well just with getting pregnant, then something simple like the birth control pill might be a good option to start with her.
Awesome. Thank you so much, Lux and Dr. Kruger, for all of the very valuable information that you've brought this evening. We had even more questions, but unfortunately we will have to wrap up due to time constraints. But thank you again from the Lois Hole Women's Society. We appreciate this so much. For those who donated this evening, thank you. If you would like to support our Women's Society, we would love that. I am going to throw up a QR code, which you can go to this evening. If you decide to sign up this evening to support the Society, you will be entered to win one of our Hope boxes, which are exclusive to our Society. Well, I'm all over the place here with my screen sharing, but hopefully I can get the QR code up here for you. And yes. I would also like to thank Blue Cross for continuously supporting our monthly talks. Without them, we would not be able to host these. So thank you again to Alberta Blue Cross. And lastly, if those who did tune in could send us your feedback, that would be greatly appreciated. You will be entered to win a $25 gift certificate, and we will contact the winner as soon as tomorrow. If anyone wants any more information, or if you have anyone who wants to rewatch our series from this evening, that will be up on our Women's Society YouTube channel as early as next week. And I think that is a wrap for this evening. So thank you all so much for coming.
Thanks, Crystal. Thanks, everyone.
Thanks so much. It was lovely.